Recognized for 5 minutes.
Thank you, Mr. Chairman, for holding this hearing. The issues that we're discussing are wrong in so many different levels, and I'm going to talk about three. One are your goals, two are your data integrity, and three is the veteran's experience. So goals are important because it defines your success. It helps you achieve your objectives. Setting a goal of 30 days is arbitrary. There is no clinical data to suggest that's the best practice anywhere in the healthcare literature. And you had mentioned how a term which earlier in the beginning of your presentation about trying to match scheduling with the clinical practice, right? So we know that some illnesses are urgent and emergent, and we need to really take care of them right away, and some others could be scheduled maybe more than 30 days, like your routine colonoscopies that you get once a year, right? So I think that you need to start perhaps changing your premise and getting more towards a clinical approach so that you can take care of your high priorities first and not necessarily rush, take up a spot for your high priorities with things that can be done in a routine basis. The second thing is setting up a goals of urgent care appointments within 30 days, which I recently heard of, is nonsensical. Then why are they urgent if you're going to wait 30 days? Usually an urgent is what you call your walk-ins, or maybe even within 48 days when you want to match your clinical practice with your scheduling goals. The third thing that I'm concerned about in terms of your goals is the use of the word same-day access for all primary care and mental health. You're setting yourself up for more controversy by not clearly defining to the veteran what access is. Is it going into picking up the phone and speaking with a scheduler? Is that what access means? Is it receiving the appropriate care? Is that what access means? So the second part is your data integrity. Now, we use population studies to reduce the chance that errors are done by chance, or so that we can get a statistical significant accounting of whether this is a true problem and whether this is systemic. But the only way that we can really rely on those population studies is if your data is accurate, if your data has integrity, and the GAO is continuing to find faults in the way that you collect data and how you're reporting it. So you can understand why we're still skeptical when you tout the number that 96% of all appointments have been seen within this arbitrary goal of 30 days. The other thing is the way you report data. So you're telling me that by veterans who use VetLink inside the hospitals are telling you that 89% of them rate their access good. Well, you're giving me data with a very high reporting bias. Of course they're going to rate it good because they're already on the inside of the hospital. How about asking those that don't get access, that are not inside the hospital, to tell us what their access is going to look like? So for those of us who know statistics and know methodologies, you know, we are skeptical when you report some of these reports to us that may not be as accurate as possible. And lastly, when we can't rely on population data, when we can't rely on the integrity, then we go by case studies. And case studies, depending on the accuracy and the write-up and the details, is what oftentimes we're left to look at. So let me tell you about a case of a wounded warrior who actually works in my office, who is a hero in my book, who went for his yearly checkup for the VA. He is service-connected disabled, manages well. He's prescribed medication through the VA. After waiting 30 minutes on hold, 30 minutes on hold, the veteran was notified that because he had not had an appointment in over a year, he would have to schedule a new patient appointment, even though he was not a new patient. He agreed to the appointment, asked to schedule that appointment as well. They couldn't fit him in until 134 days later. Again, arbitrary, right? As a result, this veteran elected choice, but they still said you have to come in and do your new patient appointment before you get to your choice appointment. So, one, what does same-day access mean? And two, why do these arbitrary numbers exist in the first place? And three, why do veterans need to have a new patient appointment after a certain amount of time, even though they've been getting prescribed medications, as recent as a month?
Okay, thank you, and I appreciate your skepticism. I think most doctors and politicians generally are skeptical of data, and I think that's a good thing. So let me very briefly tell you. First of all, you said it absolutely perfectly. The VA needs to clinically prioritize its appointments. It's exactly what I brought into the system. We used to have 31 ways of ordering a consult. Today we have 2. It's either urgent or it's not. There is no 30-day rule for urgent care. I don't know where you got that. That does not exist. Urgent patients have to be seen now. That's why we did the stand downs. I've never had a patient who has an urgent care need that I wasn't working to get them to be seen right away. That's our goal, get them seen right away when they have an urgent care problem. So I completely agree, and you said it perfectly. Secondly, same-day access. What does it mean? It means resolving the veteran's needs that day. If they need a prescription refill, they don't have to come in. We can do that on the phone or electronically. If they need to talk about how to understand how to use their treatments, we can do that over the phone or from telehealth. But patients who are sick and need to be seen should be seen that day. That's what we're working to get implemented. So I agree with you. We have to set expectations and explain it in a way quicker than we can do today. The last thing about the veterans' experience, look, the only thing that matters, are we meeting the needs of veterans? The VetLink system that you talked about asks them when they're in the system. You're exactly right. So we have a second survey called CAPS. It's what's used by the industry, the private sector industry too. That asks whether you've been able to get into see your doctors when you need it, both for routine and urgent care. So we compare ourselves to the private sector using CAPS. Internally, we use the VetLink system because that's a point-of-care system. So all of your points are absolutely right, Congressman, and we take them to heart.
Thank you.